Hi there, my name is Andrew Barta. I'm a physician assistant with Minnesota Gastroenterology, and I'll be talking to you today about the extraintestinal manifestations and complications of inflammatory bowel disease. So, just as an overview, extraintestinal manifestations of inflammatory bowel disease are caused by a dysregulation of the immune system, just like they are with inflammatory bowel disease. They can occur in the hepatobiliary system, musculoskeletal, ocular, dermatological, urological. Those are all very common systems that are involved. And at least 40% of patients with inflammatory bowel disease do have at least one extraintestinal manifestation. However, in some of the literature, it's quoted as high as 60%. So to start out with, hepatobiliary complications, one of the more common complications is primary sclerosing cholangitis. So this is biliary inflammation that can progress to fibrosis that can actually lead to biliary cirrhosis and liver injury. Patients that do have primary sclerosing cholangitis do have a higher risk for cholangiocarcinoma, which is a very deadly cancer. The 5-year mortality rate is about 30%. The risk for cholangiocarcinoma with PSC is about 0.6% per year. So patients with primary sclerosing cholangitis often have no symptoms at all and will only be found with lab abnormalities. Some vague symptoms can include fatigue, jaundice, fever, malaise, and sometimes biliary colic or abdominal pain. So most people with inflammatory bowel disease actually do not have PSC. However, most people, or I shouldn't say most, but patients with PSC will likely have inflammatory bowel disease. So as you can see here, only 5% of ulcerative colitis patients do end up having PSC, whereas 50 to 75% of patients that have PSC will end up having inflammatory bowel disease as well. So this is a graphic that describes the endoscopic appearance or the ERCP appearance down here on the right, where there's a dilated lumen and strictures seen, and to the left is a interpretation of how that looks within the biliary system itself. So cholelithiasis can also be seen in patients with Crohn's disease, and this has to do with having either inflammation within the ileum or having an ileal resection. Gallstone formation is caused by the malabsorption of bile acids, which then results in the depletion of the bile salt pool and the secretion of lithogenic bile, which will more likely cause stones. In regards to musculoskeletal system, peripheral arthritis is a very common cause. It's actually the most common manifestation, extraintestinal manifestation of inflammatory bowel disease. So this typically affects the larger joints in your upper and lower extremities, most likely the knees and ankles. It is often migratory, polyarticular, and asymmetric. And treatment for musculoskeletal symptoms, along with all extraintestinal manifestations, is directed at reducing bowel inflammation. Now, compared with rheumatoid arthritis and other types of arthritis, inflammation of the musculoskeletal system associated with IBD is typically non-deforming and non-destructive. And with this extraintestinal manifestation, it can affect up to 62% of inflammatory bowel disease patients, and this is much more common in Crohn's disease compared with ulcerative colitis. Ankylosing spondylitis is another musculoskeletal component that does occur more commonly in patients with Crohn's disease. It typically affects the spine and pelvis, which produces a lot of lower back pain and stiffness. The course is very continuous and leads to progressive skeletal damage and deformity. As you can see on the graphic on the right, the healthy spine is on the left, and the two spines on the right represent acute inflammation in the middle and eventual chronic damage, which ends up leading to a fusion of bones or a bamboo spine, which you can elucidate on X-ray. Ocular complications are also common in inflammatory bowel disease. Iritis and uveitis happen in about 1 to 10% of IBD patients. This is more of an urgent issue where patients will present with blurred vision, eye pain, photophobia, or headache. And typically these patients should be urgently referred to ophthalmology for further treatment, which often includes topical steroids. Episcleritis is a less severe condition. Incidence is around 3 to 4% of patients with IBD. It includes its symptoms include scleral injection, burning, and watery secretion. And on the next slide, we can see pictures of both conditions, with iritis being on the left, with the redness around the outer ring of the iris, and episcleritis on the right, where it's more of the lateral portion of the sclera. Dermatologic complications of inflammatory bowel disease also occur quite frequently with both Crohn's disease and ulcerative colitis. Erythema nodosum is seen, again, more commonly with Crohn's disease, but can also be seen with ulcerative colitis. It's typically a red, raised, tender nodule, and it's usually on bilateral tibial surfaces. The symptoms, or the rash, tends to correlate with bowel activity. Pyoderma gangrenosum is more commonly seen in patients with ulcerative colitis compared with patients with Crohn's disease. This is a skin ulceration with a necrotic center that is typically also seen on the lower extremities. Pyoderma is typically associated with more severe disease, and it can occur years before the onset of bowel symptoms and can actually persist for quite a long time, even after the ulcerative colitis is subsequently treated or a colectomy has been performed. Aphthous stomatitis, or aphthous ulcers in the mouth, occurs quite frequently and is typically seen more so with Crohn's disease rather than ulcerative colitis. Here on this slide, you'll see the representation of erythema nodosum on the left on the anterior tibial surfaces of the leg. And on the upper right is pyoderma gangrenosum, and on the lower right is an aphthous ulcer on the buccal surface of the lip. Urologic complications can occur with inflammatory bowel disease as well. Kidney stones or nephrolithiasis become more common with patients with Crohn's disease compared with ulcerative colitis. Calcium oxalate stones are more common because of the impaired absorption of oxalate, which makes it more soluble and readily absorbed in the colon. You can also develop enterovesicular fistulas with penetrating Crohn's disease, which then causes a whole new host of problems. Thromboembolic disorders have been seen with both types of inflammatory bowel disease. The prevalence is about 8% among inflammatory bowel disease patients, and is more common in patients that have had a family history of PE. This is more common in patients that have very active inflammatory bowel disease, and especially more common when patients are hospitalized in more sedentary and hospital beds. And in those patients, you need to be very cognizant of that risk so that they have DVT prophylaxis when they are admitted. So in summary, ulcerative colitis and Crohn's disease can have several different types of extraintestinal manifestations of their disease. Primary sclerosing cholangitis and pyoderma gangrenosum are much more common in ulcerative colitis compared with Crohn's, whereas Crohn's disease, you are at a higher risk for gallstones and renal stones, as well as arthritis and ankylosing spondylitis and erythema nodosum and aphthous stomatitis. Thromboembolic events are seen in both types of patients and are more worrisome when they are hospitalized, which is something to watch out for. And as a reminder, it would be great to see you all at our upcoming meeting in August in Chicago for the Principles of Gastroenterology for the Nurse Practitioner and Physician Assistant. I hope to see you all there.